Hello, today I will present you results of a pilot study we performed in collaboration with Dr. Appelman and Dr. Papapoulos from Leiden University Medical Center concerning bone material properties and microindentation. An available tool for the estimation of fracture risk in the clinic is BMD by DEXA, yet it is pretty well accepted that it does not correlate that well with fracture incidence. So new techniques are being developed and tried in order to see if this can be improved. One of these techniques is impact microindentation. It is a minimally invasive reference point indentation technique that measures tissue-level properties of cortical bone. The principle is basically that you shoot a needle with known force at the mid-tibia of the patient and you measure the depth of penetration, which would be inversely proportional to bone strength. Clinical studies have shown that this method can differentiate patient groups at increased risk for fracture from control groups independently of BMD values. These findings suggest that impact microindentation measures properties of cortical bone that are related to bone strength but are not captured by BMD. Such properties may include bone structure and composition. A recent study by Boltzmann et al. Showed that BMSI is not associated with cortical bone microstructure, including cortical porosity and cortical tissue mineral density, measured by high-resolution computed tomography. However, the relationship between BMSI and bone tissue composition has not yet been fully determined and remains a subject of investigation. In this work, we examined bone material properties that influence bone strength in iliac crest biopsies obtained concurrently with measurements of BMSI by impact microindentation in patients with different bone disorders with a wide range of BMD values, so as to identify potential correlations between material properties and BMSI values. The technique we used was Raman microspectroscopy, and we analyzed areas that were roughly equivalent to what microindentation measures. So that would be, as we have the iliac crest biopsy, we went at the outer edge of the cortex, and we measured right at the periosteal edge, where we have the border between the mineral and PMMA, and then we went 5, 50, 100, and 500 microns inwards. In that case, we cover pretty much what is measured by impact microindentation because clinical experience referred that this does not penetrate more than 350 microns from the cortical surface. The parameters that we determined were mineral and organic matrix content and mineral to matrix ratio, mineral maturity crystallinity, nanoporosity, glycosaminoglycan content, and pyridinolene content. Just to give you an idea, this is a picture on the left side of the cortical compartment in one of the subjects that we analyzed, and on the right you can see an example of where the Raman measurements were obtained. This is the periosteal edge, and this distance is 100 microns. And as I will show you later, whatever correlations we see were in more or less than 50 microns. In addition, we explored correlations between BMD, QBI, and Raman outcomes with BMSI values. These are the characteristics of the patients that the doctors gave us. There were 12 patients, 8 male, 4 female. The age range was between 15 to 60 years old, and a mean age of 48 years with the different bone disorders. BMD values were measured by DEXA at the lumbar spine and at the right hip. And as you can see, there is a big range between the BMD and the BMSI values within these patients. No significant correlations were measured between BMSI and BMD values, either at the spine or the right hip. In addition, quantitative backscattered electron imaging was performed, and the results of this analysis showed that there were no significant correlations between the bone mineralization density distribution of the parameters that were examined with BMSI values. Concerning Raman results, these are the tabulated outcomes of the Pearson R and P values for the parameters that we examined versus BMSI at the 5 anatomical positions. Significant correlations are highlighted in yellow. The analysis of the bone samples from the outer periosteal edge up to 500 microns inwards revealed no relationship between either organic matrix content or mineral to matrix ratio with BMSI values. Furthermore, no significant correlations were observed between the mineral maturity crystallinity and the BMSI values. On the other hand, a weak but significant positive correlation was observed between the mineral content and the BMSI at the periosteal edge, and a stronger one at 5 microns in from the edge, while further into the tissue, no correlations were observed. Concerning the relationship between BMSI and nanoporosity, a significant negative correlation was observed at the periosteal edge and at 5 microns in from the edge. From 50 microns onwards, this correlation is lost. Whereas a positive significant correlation was observed between the BMSI and pyridinolene content at the periosteal edge and at 5 microns in from the edge. From 50 microns onwards, this relationship is lost again. For visualization, we chose the patients with the 2 highest and the 2 lowest BMSI values, and this is how nanoporosity and pyridinolene proceed as a function of increasing distance from the periosteal edge. Here it is shown the relationship on the upper panel, the relationship between the nanoporosity and pyridinolene at the periosteal and the mineralized periosteal edge and at 5 microns in distance from the edge, and on the lower panel, the relationship between nanoporosity and glycosaminoglycans. As you can see, nanoporosity is inversely related to both pyridinolene and glycosaminoglycans. Now, this study has a few limitations. One is the low number of the patients that were studied, and the other that the BMSI measurements were obtained in tibia, while the results of this present study were obtained in iliac crest biopsies. So, to summarize, there was no relationship between BMSI values with any measurement of mineral content or mineral maturity crystallinity. On the other hand, a positive correlation was observed between BMSI and pyridinolene at the mineralized periosteal edge and at 5 microns in from the edge, and a negative correlation between BMSI and nanoporosity was found at the same locations. The relationship between pyridinolene and nanoporosity could be explained by the decreasing in the fibril spacing with increasing in pyridinolene content. Concerning glycosaminoglycans, we saw significant correlations with BMSI values only 5 microns in from the periosteal edge. This could be in part because there is a relationship between canalicular network size and density with BMSI, because it has been reported that there is a positive correlation between local mineral content and the canalicular network density. Now, the fact that we didn't see any correlation concerning glycosaminoglycans with BMSI values right at the edge could be due to the fact that canalicular network is not yet mature enough to influence the initial penetration. So, another thing is that the absence of the relationship at greater distances could be due to the fact that once the tip breaches the periosteal edge, it compresses bone material as it penetrates deeper into the mineralized tissue. Thus, it could be hypothesized that the depth of penetration during these measurements depends on the material properties of the outer mineralized surface of the cortical. These results indicate that local mineral content, pyridinolene and nanoporosity are likely linked, that are measured at the periosteal site, are likely linked with BMSI values measured at the tibia. So, in conclusion, this study gives a plausible hypothesis leading to an explanation of impact microindentation results based on material compositional properties of bone that still needs further evaluation in a larger group of patients. Thank you for your attention.
Well done, Dr. Rokidi. Nice study, well presented. I enjoyed a lot because I like that you use the Raman spectroscopy. So you compare different variables to the Raman spectroscopic findings. Why did you use the Raman spectroscopy?
We just wanted to see if BMSI correlates with anything. We didn't want to examine if fracture can be predicted. So we use this technique because we can measure, apart from the mineral, the organic matrix.
Excellent.
And
so
all
this is the correct answer, because you can use also other spectroscopic studies.
And also because we could go specifically at the locations we wanted.
And also this is more useful for in vivo studies and biomolecular, because other spectroscopic studies need to be dehydrated the tissue. Any comments, please? Any comments from the audience, from the floor? Yes, please.
Beautiful work. I was a bit surprised by the lack of correlation between the BMDD data and the BMSI. Yeah. So do you know if there are other literature data in other patient cohorts? Because you also had the positive that you had a wide range of BMD, so you didn't find it either on the high or on the low bone mass.
I wouldn't say it was that much of surprise that we didn't see any. Yes, sorry. That we didn't see any correlation, because BMD has to do with a huger volume of bone mineral, and here with the BMSI it was located in a more specifically.
The BMDD, I mean.
Yes.
The QBI.
Yes,
yeah.
the QBI. Yeah.
So
the measurements were through the whole cortical surfaces.
There are no more questions. Thank you very much for a lovely talk. Our next speaker is Manuel.